Hi, good evening, everyone. This is Moonlight Lee. I'm the founder of Unlocking ADHD. Welcome to our January 2024 program lineup. This is the second of a two-part series on ADHD medication, and we were really overwhelmed with the response and interest in this topic because we know it's such a complex topic.
So last week we covered some generalizations about what ADHD is and the complexity of diagnosis. And I've tried to make a strong case for treating ADHD with medication as a cornerstone of a comprehensive treatment plan. We talked about how to do a medication trial in a controlled way. And this week we're going to be talking about troubleshooting, managing side effects. What about when a medication works, but it doesn't work long enough? It doesn't cover enough hours of operation, that uneven medication coverage dilemma. And then what I call discontinuation trials. When is it appropriate to do a trial off the medication? And if we have time to touch some on non-pharmacologic treatment beyond medication, educational care, behavioral care, psychological care, I'm happy to dip my toe in those important waters as well, but the primary focus of these two workshops has been medication management. So you can find a more detailed discussion of the principles discussed in these 2 weeks in my second book, Parent-Child Excursions. If you're interested in non-pharmacologic approaches, not just to ADHD, but to the range of developmental differences, the first book, Parent-Child Journey, and the courses on the QR code, feel free to check out parentchildjourney.com. So we're going to be covering these most common side effects. This is not a complete list of possible side effects with medication, but it's the ones we see most often in real life. So impacts on nutrition and growth, the appetite suppression, the potential for poor weight gain, impact on sleep, trouble falling asleep, staying asleep, other sleep disturbances, negative mood, anxiety, obsessive compulsive tendencies can be amplified by ADHD meds. We talked a little bit last week about the impact medications can have on personality, on social functioning with some flattening, too much inhibition, that loss of sparkle, social withdrawal, which is not okay. None of these side effects are okay. Let me emphasize, these are side effects we're going to monitor for and manage and not just tolerate. Attention can be worse on some ADHD medications. You can have hyperfocusing, getting stuck, and especially kids who have coexisting autism and ADHD, you can have amplification of autistic tendencies to get stuck and hyperfocus. And then the involuntary motor behaviors, either vocal tics, motor tics, and then the nervous habits, picking, pulling, twirling, chewing, any other repetitive habit, and then some physical symptoms, headaches, stomach aches, nausea, dizziness, drowsiness. So these are the ones we'll focus on, but I'm glad to take questions about side effects not on this list. So we talked last time about how to do a medication trial where we start with target symptoms, distractibility, hyperactivity, impulsivity, difficulty with school, difficulty with work, difficulty in relationships. These target symptoms would be filled in, and Moonlake and the team will put a link to my medication trial forms on my website that fill in these blanks for you for school-age children. But Dr. Bhanu will have some ideas about what to look for regarding adult target symptoms. And then we'll list possible side effects, all the things I listed on the previous slide. And as we do a medication trial, we make sure that as these 2s and 3s, medium to big problems, hopefully come down to 0s and 1s, that we don't have an increase in the numbers for possible side effects. If we do, we need to respond. So side effects can be controlled, they can be minimized, and the idea here is to have life-changing benefits and no significant side effects as we tune the medication and get it just right. A few general principles about managing side effects. We want to have realistic expectations. I want to describe some common patterns. I want to describe what I mean by observer bias and what I mean by monitor, accommodate, or treat. So I'm going to cover those general principles quickly in the next slides. So realistic expectations and trade-offs. So the most common cause of medication failure is side effects kicking in before benefits. They may kick in before we get to a beneficial dose, and that's not okay. We shouldn't increase the dose of medication in the face of side effects. Different children will be prone to different side effects. So if you have a tendency to be a poor eater, a poor sleeper, if you have a tendency to be anxious, you would be more at risk for those particular side effects. We have a dilemma. How do we live with a side effect versus live with undertreated ADHD? We don't want to live with either. I want that to be the take-home message today. We want to have minimized side effects, maximized ADHD control, and not make a trade-off if we're patient and work through this process. So we'll talk today about managing those side effects. And the idea here is do not continue a medication where that risk-benefit ratio is not strongly favorable. If you think about medication kick in when the medicine is taken, it takes some time for the medication to achieve an adequate blood level. That's the kick-in time, the time from taking the medicine to the time it starts working, or the time it starts causing a side effect, when it's getting to that blood level where things happen. That's the kick-in time. The peak is when it's at its highest blood level. And then there's the kick-out time and the trough, the bottom part of the medication blood level curve. So when does a side effect happen? Is it as the medicine's coming up in your blood, as the medicine's at its peak level, or only what we call rebound as the medication is wearing off? Management of side effects depends upon the timing of the side effect relative to the blood level of medication. Side effects can happen as we are just increasing a dose of medication, a relatively immediate problem, or it can sneak up on you gradually over time, in particular with tics or mood side effects. Some side effects are observed only by parents, teachers, or doctors and not noticed by the child. Other side effects are noticed by the child and not noticed by the adults. We listen to everybody and take everybody's concern about side effects seriously. Some side effects will get better if we just hang in there and let a child acclimate to the dose. Other side effects, we don't hang in there because they're not going to get better. More on that to follow when we talk about specific possible side effects. I want to just mention that there can be some observer bias regarding side effects. By this, I mean some people are so excited to get their child on medication, they want to help, and they might underreport, downplay the significance of side effects. And a good doctor has to ask very specific questions to uncover that minimizing bias. On the other hand, some parents understandably have a lot of concern, even anxiety about side effects, and might maximize, even catastrophize about the side effect and over-report when it's not having that much impact. So all side effects are not created equal, and let's beware what we bring to the table as parents and as doctors when we're interpreting the significance of any side effect. So here are our side effects again, and nutrition, sleep, mood, personal, social, attention, involuntary motor behaviors, and physical symptoms. And the idea here is to ask, oops, I'm going to go back a slide here, whether to just monitor, for example, if you have just a little impact on appetite, but it's not really interfering with overall growth, you might just monitor. If it's not causing significant hypoglycemia and irritability during the day, you might just monitor. On the other hand, if there's such significant appetite suppression that it is having an impact, then you should consider reducing the dose or changing the medicine. If you try a bunch of different medicines and you can't avoid appetite suppression, this is one side effect that you could potentially treat when all else fails with some appetite stimulating medications like cyproheptadine, an antihistamine that increases appetite, or mirtazapine is an antidepressant, anti-anxiety medicine that can increase appetite, treat anxiety or depression, and help with sleep. Dr. Bhanu can help me with which of these medicines is available in Singapore. So I'll need some help from my colleague on that. So just to highlight the thinking on the nutrition front, but this idea of, hey, do we monitor if it's mild and tolerable? Or do we try a different medication if it's not? Or do we have to treat if it's unavoidable that monitor, accommodate, or treat? Accommodation of nutrition might be just timing meals when a medication is wearing off and catch that wear off time, for example, in the mid-afternoon as a long-acting medication is wearing off, or in the evening. If we can't eat our dinner, we might have a second supper before bedtime, and breakfast, obviously, before medication kicks in. That'd be where we accommodate by timing meals away from the medication peaks. So that logic applies all the way down the list. And in the Q&A, we can talk more specifics. I want to talk briefly about what I call trough tracking, shifting topics here to when a medication works. What about these troughs before the medication kicks in? That's a morning trough. The blood level is not quite up to therapeutic level yet. And when the medication is wearing off, there's another trough here, often in the mid-afternoon or late afternoon. So you should know what the time to kick in is, what the time to kick out is, and think about whether or not there's impairment because of uneven coverage. Sometimes a medication isn't working because these troughs are happening, this uneven coverage before medication kicks in and after it kicks out, and that's fixable. You can have trouble with the morning routine, with the morning trough, after school, evening, etc. And there are repercussions regarding this. Some parents get blamed if a child's doing well at school, but the medication wears off and they're not doing well at home. Some teachers get blamed if a medication kicks out at lunchtime and the morning teacher's having an easy time, the afternoon teacher's having a hard time. What's that afternoon teacher's problem? Well, it's not the teacher, it's the medication wearing off. And the child might feel that, hey, I can't beat this ADHD thing when it's just a trough. So we don't want parents, teachers, or the child blaming themselves when it's just an uneven medication issue. I see this all the time. An underappreciated issue with ADHD management is this trough filling, this low blood level, not giving us adequate coverage over the course of the day as much as is needed. So early morning troughs, afternoon after school, and early evening troughs, bedtime troughs. I'm just going to rifle through some strategies. Again, there's more detail in the book or in the video course at parentchildexcursions.com or parentchildjourney.com/excursions, sorry. But just to quickly give you a feel for early morning troughs, well, if you're using a standard long-acting medicine that's not kicking in quickly enough, you can use a short-acting medicine, and then long-acting medicine, what I call short-long. Or you could give a nighttime non-stimulant like extended release guanfacine or clonidine, give that at nighttime and have it carry over to the morning and hopefully fill the trough in the morning that way. Or in the United States, not available, I don't believe, in Singapore, but maybe you guys will be getting it. There is a Jornay is the brand name. You take it at night around 8 p.m. and it delays its release until morning, and then it dumps the medicine before your child wakes up and fills that morning trough in that way. So these are just some ways to fill an early morning trough. For an afternoon trough, you can go with longer acting morning medicine, and there's some options available. There's a long short option, long acting followed by a short acting medication. You can go long. This happens if, for example, you've got a long-acting medicine that's wearing off after lunchtime at school and the child needs help for the second half of the school day and for after-school homework or activities, or for people in a workplace, adults, where long-acting medicine with a second long-acting dose after lunch or at lunch, or you can give a non-stimulant again in the afternoon, just give it earlier so it kicks in as the morning dose is wearing off. Bedtime troughs, same idea. Fill that with a short-acting medicine or a non-stimulant. You get the idea. So you need to know the kick-in time, the kick-out time, and is there a problem during those periods of time where there's inadequate blood level of medication. Sometimes we want to fill those troughs, from dawn until bedtime. Sometimes we want to allow for a trough if we want a little more appetite, or we want the medicine wearing off at sleep time, or for specific activities where a child doesn't want to be so medicated. This is the art of medicine, the fine tuning, and it's super, super individualized. A brief word on discontinuation trials. We stop medication if we're not sure whether the medication is still needed. Sometimes parents aren't sure. Sometimes the kids aren't sure and need to experience their symptoms to become aware of what difference medication makes in their life. And I'll do a time-limited, controlled trial off medication for those reasons. Sometimes we're not sure if a side effect is being caused by the medication or if it's unrelated, or if it's caused only in part. The way to tell is by stopping the medication and monitoring the side effect. If it improves or if it stays the same, that will guide subsequent management. Sometimes these discontinuation trials are done by accident. If a refill for a medication doesn't come through the pharmacy on time, or if people forget to give the medicine, or they forget to take it on vacation. I prefer that these are done in controlled ways with using the treatment trial scales and having the child as observer, a parent, and at least one teacher. For school-age kids, again, Dr. Bhanu will address these issues in adult life, but the idea is to be scientific about it and gather the information that's needed, both in terms of whether a side effect disappears and how much worse the ADHD is when we try discontinuing. So this is a trial, this is an experiment, not a decision carved in stone. I emphasize that to the children and the families whenever we do these experiments. So just what I talked about before, we'll use the scales to get a current baseline on the medication and then follow-up data as the medication is discontinued, with all this data coming to the prescriber. So some other references that you all, I hope, will find helpful, and I will turn it back over to Moon Lake at this point. So hope that was a helpful whirlwind tour.
Thank you very much, Dan. Honestly, I think when I hear you and sharing all these details, I don't think many people have heard something like this before. So that's very thought-provoking, but also very practical. I particularly found it amusing you talked about the partner or parent blaming, because I definitely have been there before. So thank you. You made it very real for us. So I'm going to bring Dr. Bhanu on, but just before I do, I'd like to just introduce him again. So Dr. Bhanu is a senior consultant at the Institute of Mental Health. He was the program director, has been the program director for the graduate diploma in mental health run by IMH at the National University of Singapore, and he's a special interest in adult ADHD, which is why we have him here today. And Dr. Bhanu worked in the UK before, and he was also involved with ADHD. He was the lead in the Institute of Mental Health Adult ADHD Clinic for 4 years. And he continues to be quite passionate, interested in keeping up to date on developments here. He's also on the World Anti-Doping Agency panel, and his research interests include ADHD as well. So Dr. Bhanu, welcome, and thank you for being with us. So I want to start off, Dr. Bhanu, by maybe asking, what are your thoughts, based on what you hear about Dr. Dan sharing, and how does this apply in the Singapore context?
Yeah, I think first of all, thanks very much, Moonlight, for inviting me. I think it's an honor, and certainly an honor to be alongside Dan. So thank you so much. I think it's a fantastic presentation. Most of it very relevant to us. In fact, all of it very relevant to us. Just tells me how, even though we are across the world, things are much the same, and the condition is the same, the treatment is largely the same, and probably the issues that we encounter are also the same. I think, I've sort of, I don't see children, so I've been mainly dealing with adults, and there are slight differences, as you alluded to within your talk, Dan. in terms of the side effects, I mean, I think the side effect about the appetite suppression, which is such a big deal for children, less of a problem for us. I think a lot of the time people are just okay with losing weight or not eating. Of course, it's not ideal if you're not getting enough nutrition. So we emphasize on that, and we emphasize how you should be using the medications. Certainly not skipping a breakfast. It's so important, the first meal of the day. But overall, the sort of appetite part is not that much of a problem. Having said that, there are some people who are underweight, and then we need to sort of do something about it. And I think you asked whether we have cyproheptadine or mirtazapine. So in my practice where I work, it's mainly mirtazapine. Again, if there is comorbid depression or any other condition, anxiety, which can be helped, it's even more helpful if you prescribe something like mirtazapine. And we do it sort of based on what the profile of the patient is and what they want. The other part, of course, is to reduce the dose or to sort of try something else if a particular medication is causing appetite suppression. Insomnia is another big issue.
Bhanu, if I may interject one
Yes, sure.
quick point here.
Yes.
A source of medication abuse
Mhm.
is seeking stimulant medication for the purpose of weight loss, and anorexia nervosa patients will often become psychologically addicted to these medications because, and I'm sure you see this, Bhanu, as well. So just slide that point in there.
Yes, yes. I mean, I think that the issue about the abuse, and I think one of our common fears as a psychiatrist working in this field is how many people are potentially going to abuse. And I must say, I think like your experience, what you related last week, most part, I've hardly seen people who come to us abusing the medications. And if anything, we have a difficulty in getting them to take the medication rather than, taking too much. So yeah, so insomnia was the other issue that I was mentioning. And I think, again, we sort of look at sleep hygiene issues. We see whether it was baseline sleep was a problem, and that's where the insomnia is coming from. Of course, it can be the side effect of the medication, and then you have to see whether you give a shorter acting one so that the trough hits at the right time and people can sleep. And then finally, sort of things such as melatonin, which are available over the counter in Singapore, can help. Rarely do we prescribe medications to help with the sleep itself. I think the one thing that I would like to add is it's fascinating to see how many different preparations are there within the United States. We have very, very limited amount of medications and stimulants, and even once it's just to hit the shows. So it's only now available. And my institute, I think we are still trying to make it available. So we have a bit of a limited formulary in terms of what we can do, and we have to work around that. Yeah. So over to you, Laika.
Thank you. So there's a very common question that we've seen quite a few times, and that was about building immunity to medication. Like over time, some people said that they had to have increasingly higher dosage, but where does it end? And does the body actually build up immunity? And if that's so, what can be done about it? Like, should they take a break? And if so, how long? Maybe Dr. Bhanu, you could start first, and then Dr. Dan as well, because it might be different for adults and children.
Yeah, sure. So, I mean, in my own personal experience, I haven't seen so much of an immunity develop to the medications. If anything, I think when you first start, it takes some time to get the dose right. And I don't know whether Dan shares the same experience, but I've seen this where you start someone and they say it's wonderful, and then they say actually it's not so effective anymore. And then you have to do some adjustment to get to the right dose. But once you are at the right dose, most people remain on that. I've not seen the need to keep increasing the dose. So there's not a tolerance that develops. And yeah, I would be very interested to hear what Dan's experience is on this.
Strongly agree. Strongly agree. I didn't know which way you were going to go with the answer, to be honest, but I strongly agree. That's been my experience, and the research bears that out. My experience is that when there's the feeling that you need to keep increasing the dose and increasing the dose and increasing the dose, it's time to go back to the original diagnostic considerations.
Yeah.
Why should that be happening? Not because of building up of tolerance. Almost always, it's because of a coexisting condition that's gone underappreciated. For example, the child, as we talked about last week, who has inattention, impulsivity, motor restlessness because of a coexisting problem with anxiety or depression. A child who's not attending because of a coexisting learning disability, executive dysfunction. A child who's not attending because of a coexisting social disability like autism, et cetera, et cetera. So if you are finding that, hey, you got a good response to medication regarding the core ADHD symptoms, but it's not a durable, lasting benefit, think about what you're missing in terms of coexisting conditions. As we emphasized last week, coexisting conditions with ADHD are the rule rather than the exception. So ADHD medicines don't treat learning disabilities or anxiety. And as I mentioned, sometimes ADHD medicines can make anxiety or depression worse. Don't increase the dose in the face of a side effect. So a really great question and an important point, I hope.
And a really great answer too. So thank you. So just following from that, can ADHD medication help with executive function, or is it a coaching thing, not so much a medication thing, or a combination?
We used to say, and I think we still do, that executive dysfunction is a type of learning disability, complicated. By executive dysfunction, we mean difficulty initiating, sustaining, inhibiting, shifting, time management, planning, organization, all of that. If you had an executive secretary, what they would be helping you with. When do I start? When do I stop? How do I pace myself? So to the extent that distractibility, impulsivity, sabotage executive function, to the extent that distractibility is the source of difficulty with executive functions, then medication can secondarily help. But if the executive dysfunction is in large part a coexisting condition, not entirely secondary to ADHD, which is usually the case, then we think of it as a type of learning disability where we're talking non-pharmacologic management with coaching, with environmental control, et cetera. So that's the generalization. Recently, there's been some interest in the impact of norepinephrine reuptake inhibition on executive dysfunction. So two main pathways for ADHD meds. One is through the dopamine pathways, the other is through the norepinephrine pathways. Different medicines hit those pathways in different ways. It's felt that the ADHD medicines that hit norepinephrine receptors might have a direct effect on executive functioning. The word is not in on this, but I've had to modify what I used to say, that executive dysfunction is not about medication at all. The answer now is maybe, but still we're talking primarily non-pharmacologic. Bhanu, I don't know how you feel about that.
I mean, I think it's a complex question to answer. It's not straightforward. Yeah. The reality of it is that, other than the inattention part and the hyperactive part, the executive function plays a very important role in terms of, the impairment that it causes. And it's probably sometimes why people seek attention, because they're just struggling in life. And executive functions are so important. You need to be able to pay attention. You need to be able to organize yourself, not procrastinate. And to some extent, I would say that people, if you don't get that, if there's not enough improvement there, a lot of the time people drop out or they won't continue with the treatment, because that's sometimes, at least for the adult population, that's why they are seeking help. So I think it's, I mean, I have seen good effect of the medication on executive functioning to the point where people find that many of these tasks that they struggle to do in the past, and also what comes with executive functioning is the emotional regulation, and that is sometimes so important. If people can't control their emotions, they get into all kind of troubles, or the relationship doesn't work out. So medication does play a role as much as other things play a role. Now, it may not happen in all the cases, and sometimes it only plays a partial role, and you still have to sort of train yourself and learn other skills. And that's why, as much as we say medications are the first line, the treatment is always multimodal, and you probably should involve things such as looking at how you can improve upon all the facets of life where you're struggling. And a lot of it is psychological help rather than just medication. So I think medications do play a role, an important role, and sometimes can make considerable difference. But largely, I would still think the best treatment is multimodal, where you address both.
I couldn't agree more. Medication is necessary for improved executive function, but it may not be sufficient.
Awesome. And I like to use the analogy sometimes when I share with parents and other persons who are new to the concept of medication. It's really like wearing a pair of glasses. Trying to learn how to drive, you need to have a pair of glasses so you can see better, right? But you still need to know the skills of driving. So it really is a combination. So thank you for that. And following up from this question is really the question of consistency. How consistent do you need to be? Because there are parents who say, you know what, I don't want my kid to take medication except maybe before the exam. Same thing for adults, right? Actually, you know what? I want to be creative. I want to be like the real me, my strengths. But when it comes to income taxes, right, or filing receipts, I need medication. So I just take it as needed. So what is the best practice here for this?
Okay, so this is one of the things that we, at least in my practice, I very commonly encounter. I think there's only a small portion of my patients who would actually take medications regularly, including weekends. And the ones that who do seem to derive a lot of benefit and understand that this is not just about, being able to complete a task or doing well in your exams. This is much more than that, and it's affecting their life. And hence they think that it's really helpful. On the other hand, when people come as an adult for diagnosis, they're kind of set in their ways in some sense. And they're not quite there to change their personality or to sort of do an overhaul. They're there to achieve something that they're struggling to achieve, and in that process they may discover that actually the medication is helping me in other aspects as well. But for most part, I think my patients usually don't take it very regularly. And again, unlike children where the parents are there to remind them, sometimes even to remember to take the medication is such a challenge. So out of 5 days, they may realize, okay, looks like I didn't take my medication today or this morning, or I just completely forgot about it. So again, for me, the idea is to give them the choice, the pros and the cons, and they need to decide for themselves what works better. I would like to spend the time psychoeducating as to how the medications work, what kind of impact you can see from it, what kind of positives you can get out of it. And that includes not just, improving, finishing a task or something. It also is other aspects. And we discussed about the executive functioning and the procrastination and time management. So it can help in several different aspects. And some people feel that that's important for them. On the other hand, some people think, no, I just need it during my exam time. And once I'm done with that, I don't really want to rely on the medication. That's a fair choice. So I go by what the patient wants, and what they tell me. I think I've long given up on forcing people to take medication. I think I'm beyond that. I mean, the overall compliance rate for any psychiatric medication is pretty low. I think about only 40% people take their medications regularly. So I can't expect the same from my patients. But as long as they know how it works for them, and they're able to work it out how to derive the maximum benefit without having the side effects, I think that's good. So you can decide what works for you.
Again, agree. The burden is on the prescriber to educate the person with ADHD about the impact beyond school or beyond the workplace. So as a pediatrician, we talk about ADHD not just being an academic performance issue, but it's a life issue. And some people just don't know that, and they need help connecting the dots. So that's one consideration. And again, I'm a big believer in controlled trials. If somebody's not sure how much impact ADHD is having outside of their school day, we say, hey, let's do a trial on weekends for a few weekends and then off weekends and see what you think, see what your parents think, and gather some data. And without jumping to any conclusions, I think it's fair to say some people need medication on the weekends or vacations more than others. So it's an individual thing. Stopping and starting stimulant medication, nothing bad will happen, but there are some individuals who will experience more side effects stopping and starting. There can be a little difficulty, getting used to the medicine again if every Monday you're starting over. Non-stimulant medications do work better if they're taken regularly. Stimulants pretty much work the same if you stop, start, stop, start. Non-stimulants, you're going to lose some effectiveness if you stop and start. And there are some medications like guanfacine and clonidine where if you're on a higher dose for a longer time, you do need to taper it down to avoid some rebound cardiovascular side effects. Not common, but so there's the minimizing side effect part to the inconsistent taking that applies to some people more than others.
Yeah, I think thanks for pointing out there are stimulants and non-stimulants, and I think my answer was primarily about stimulants, which is the first line. But yes, for non-stimulants, you should take them regularly. That's how they work, and they work best to take them regularly. Yeah.
Yeah, and also the fact that we're all different in our wiring and in our presentations. Because I know people that need the medication just to get out of bed, to get the engine started, so to say. Others just jump out of bed, but then they're all over the place and they need the meds to sort of, slow them down a little bit. So it's going to be different for everyone. So again, when in doubt, go and see your doctor, okay? Not just Dr. Internet, right? The other question I had here, and this is for Dr. Bhanu specifically. Last week, we asked Dr. Dan, how young is too young to start medication? So now the other flip side, how old is too old, to get a diagnosis and to get medication?
Yeah, so I think as much as I would like to say it's never too old, there is the practical side of it, which is the bottom line is how much it is affecting your life and what do you want out of the diagnosis. Do you just want an explanation of what's going on in your life? And you'd be surprised, a lot of the time we will get patients who just want to know whether they have ADHD or not. They don't want to do anything about it, but that just gives them an answer to a lot of things in life. So as you grow older, of course, you've kind of lived your life, and we're talking about sort of people in their 60s, perhaps, or 70s. And I think I have prescribed medications to people in their 50s and early 60s, I would say. But I know there are case reports where people have continued to take medications or have been diagnosed much later. However, there are those additional issues that also become relevant, which is one, are there any cardiovascular issues or are there any medications that a person is on? And if you're going to start on the stimulant medication, these are aspects that you need to think about. And a lot of the time, people at a certain age, late 50s, early 60s, the demands are not that high. On the other hand, they may still be struggling with things such as, being more forgetful, being very chaotic, not being very organized, and therefore treatment can make quite a bit of difference to the quality of life. I hope that answers more like
Very complete. Thank you.
Thank
Yeah,
you.
it runs in family. So I have to say that in my own family, I've had, several relatives diagnosed in later years. So, it's not an uncommon issue, and I think I've received questions on that. So Dr. Dan, there's another question here now about using coffee or caffeine as a form of daily medication. Okay.
Salud. Yeah.
Oh, yeah, you're showing a coffee mug there. Okay. So
Yeah.
then the question is, maybe someone hasn't been diagnosed, but they have certain traits and they're just drinking a huge amount of coffee, right? Is that one way of medicating? And what if they did get diagnosed and they would prescribe medication? Could they combine it?
Yeah. So we all know the effect of caffeine on attention. It works. It works. That's why I've got my cup right now going. And I wanted to be focused and attentive during this hour. So it's working for me. The problem with caffeine, not just coffee, obviously, but tea and Coca-Cola and you name it. The problem is it's not a very good drug. It has a very short half-life, it wears off. Caffeine is something you do build up a tolerance. You don't get the same bang for the buck. One cup becomes two, becomes three, becomes four. And you do have more powerful withdrawal symptoms actually from caffeine once you get escalating. So that's why Starbucks is doing so well, right? Because it is an addiction. They are marketing that addiction very profitably. And so the other issue is it's a wonderful diuretic. You drink too much caffeine, you're going to be going to the restroom a lot. You're going to stain your teeth. You're going to have more gut rots, more acid reflux. The risk-benefit ratio for our prescribed stimulant medications for ADHD is superior to caffeine. So if you need a little hit of caffeine here and there, you're enhancing performance. You're not treating a neurodevelopmental disorder. Cool. If you have day-to-day functional impairment, you can do better than caffeine if you're choosing a drug.
Thank you for that answer. I think it might meet a lot of questions that people have out there because definitely coffee is one of the drinks of choice, right? I'm going to go back to Dr. Bhanu here, and this question is more for women with ADHD. As we know, there's going to be differences in terms of the hormone fluctuation at different stages of life, and one of the key stages actually is pregnancy. Okay, so if a woman who has ADHD is pregnant, what happens? Should she continue taking the ADHD medication? What would you say to that? And then the follow-up question is, after delivery, there's some research that talks about the higher risk of postpartum depression. And then again, how do you manage that?
Yeah, so I think it's a difficult question to answer because one, we don't have a lot of evidence. You can't really do studies on pregnant women, and the evidence that we have is mainly around people who chose to take the medication whilst they were pregnant, and then to look at their outcomes as to what happened when they delivered the child and subsequently. And there is a higher risk in pregnancy of children or the unborn child being affected, but the risk is only slightly higher. So if you look at it, you're looking at a risk-benefit ratio again. But for most part, if you look at the medications and what the insert says, they say it's not suitable or not recommended for use during pregnancy. So if you were to ask me, can I continue my medication? I would say no. If you plan to get pregnant, well, first you should plan it, and then as much as possible, you should try to come off it. And only in a situation where the medication is extremely important for you to maintain, then we look at what type of medication, and is there something that we can give which is sort of slightly better risk-benefit ratio compared to, let's say, stimulants, then we can try and prescribe. So I think most times people do plan when they want to get pregnant, and this can be tackled with a bit of planning. We do that for other psychiatric medications as well. So when people are taking antidepressants or antipsychotics, it's sort of similar advice. You sit down, you tell them what the evidence is, what are the pros and the cons, and then let the person make an informed decision. So in general, the advice is no, you should not take it as much as possible. But of course, you can take an informed decision based on what evidence there is and what kind of medication you're taking. The first trimester is usually the trimester where the sort of bulk of neural development happens. So sometimes you would say, okay, try and avoid it for the first trimester, and then subsequently you can be on it safely or with monitoring. So that's slightly better, but overall, I'll say it's not really recommended as per guidelines. And the same holds true for breastfeeding as well, that it is excreted in breast milk, most of the stimulants. So you will, the child will be affected. So if you're planning to breastfeed, then you need to know about that. Yeah.
Thank you for answering it, because I don't think people know much about it or even think of asking this kind of a question. So I think it's one of the rare questions that we heard about in Singapore, at least it's publicly available. So thank you for that. The other question here, again, a very common one is, how does it feel like if medication is working effectively? I find that I still struggle with staying focused while on stimulant medication, and I still have those side effects like the high heart rate and suppressed appetite. Does it mean it's not appropriate, or is it maybe I don't have ADHD?
So, partial treatment or, lack of benefit from medication means, or you have side effects kicking in before optimal benefit, which is the case presented here. That's a common situation. Means you have to go through your algorithm, try adjusting dose, try a different stimulant. If stimulant by itself doesn't work, then go with non-stimulant. If stimulant by itself gives partial benefit, combine it with a non-stimulant and see if you can maximize the benefit, minimize the side effect. And if that all isn't working, again, look for coexisting conditions. It's sometimes not all about ADHD, but again, the most common thing is coexisting anxiety and depression. So, so go back to the drawing board, go back, don't give up. Don't give up. The majority of people with properly diagnosed ADHD, we're talking 80 to 90% success rate, folks, with at least a substantial partial benefit, where on my scales, 2s and 3s come down to 1s and 2s. That's worth having. That's partial treatment. 2s and 3s, you hope will come down to 0s and 1s. That's our goal, but don't give up. Keep working at it is the main message I'd like to send.
Wonderful, thank you for that. Dr. Bhanu, last week, one of the questions that we asked Dr. Dan that came up as well, talking about comorbidities, right?
Mm-hmm.
A very common one is ASD, autism spectrum disorder, with ADHD. Right. And my understanding again is that ASD is not treated with medication, unlike ADHD. And there are sort of almost tug of war kind of traits sometimes in the same person. So, we spoke about how it affects children, but how about in adults? Because in our community, we actually seen quite a number of adults that have 2 of these comorbidities, sometimes even 3 with dyslexia. So how would one approach medication and managing symptoms?
I think I'll probably go back to the previous question as well, because they're linked, and the importance of getting the diagnosis right and essentially ensuring that when you're treating ADHD, there are not other things that need to be treated or addressed. And for most part, if you're looking at mild anxiety or depression, you should treat ADHD first, and the anxiety and the depression may just go away because that was part of the ADHD spectrum of symptoms. On the other hand, if someone is depressed, or there is a proper generalized anxiety or panic attacks even before you come for the ADHD diagnosis, in our setting, we actually do the first full psychiatric assessment first before we would assess someone for ADHD. And I think it's so important because you get a broader picture. So sometimes while people may think, and may well be true, that the diagnosis is ADHD, but there are other conditions that also require addressing or treating, and they are sometimes equally important or more important. Yeah. So if you treat someone for depression, sometimes the ADHD symptoms may not be that disabling, and you may not need to treat them, or you may need to treat them after you have taken care of the main issues. So with ASD, I think you're absolutely right that it's sort of much more apparent when you're a child, and then as you grow up, if ADHD has not been diagnosed, it's even more difficult to diagnose. And then the treatment, there's no specific medications as such to address the core symptoms, but there are additional things that can be addressed. And whether it requires stimulants or whether it requires other medications, which may include low dose of antipsychotics or sometimes antidepressants, sometimes mood stabilizer, depending on what other issues one is encountering. And then, of course, a lot of behavioral work, which is the cornerstone for addressing the main symptoms. So as much as there's a lot of people who have these comorbid conditions, I haven't seen so much in my practice combined ASD with ADHD, and a lot of them have actually been diagnosed as a child, and we have just continued to treat and adjust the medications according to what it is. Yeah. Though rarely it is that we get as an adult where someone is coming with ASD, and then you're looking at a diagnosis of ADHD and trying to treat it. I mean, I don't do that. We do have colleagues who do that. Yeah.
And that's one difference between us, Bhanu, is
Yes.
the bulk of my practice as a developmental pediatrician is composed
Yes.
of individuals with coexisting autism, ADHD, and anxiety. So this is the difference between an adult provider and a pediatric provider. So it's extraordinarily common, so common that I wrote a whole book about it. That's the Parent-Child Excursions book about the coexistence of these conditions. So it's interesting to me that as an adult psychiatrist, there's a filter there regarding which patients you see versus those little kid docs. Oh yeah.
The other question I had is to do with the effect of ADHD medication and anger management, because that question has come up as well, both from the child side as well as from the adult side. Someone taking the medication, but it seems to not help as well with the anger, the behavioral part, and what can they do about that?
Yeah, so Dr. Bhanu emphasized earlier a very important point, mood dysregulation as a part of ADHD. That's part of the executive function piece, being able to stop and think about one's emotional reaction. Hugely important regarding ADHD. So studies done on irritable, explosive children emphasize the importance of looking hard for ADHD as a contributing factor, if not the primary contributing factor. And in a large percentage of children with irritable, explosive behavior, anger, if you will, aggression, property damage, etc., a large percentage will respond nicely to ADHD medication. So that's a cornerstone of treatment when ADHD and mood dysregulation coexist. But often it's not adequate. Often you need to combine an ADHD medicine with the medication that helps with the coexisting anxiety that can spill over to aggression, depression that can spill over to aggression, severe mood fluctuations on the bipolar spectrum that can spill over to aggression. So it's not unusual when you have ADHD coexisting with mood dysregulation to need to combine medications for ADHD and mood. It's important to have that wraparound comprehensive pharmacologic and non-pharmacologic intervention for these patients.
So the anger issues, there's a huge overrepresentation of people with ADHD in let's say prisons and elsewhere because they got into trouble. It's just a function of their impulsivity, for example, and you just kind of go ahead and participate in a riot simply because your friend told you to do that, you know. So it's one of those parts where ADHD, if treated and treated at the right time, can make a difference. And anger is one of those things which, you know, you can benefit from it. Again, combination of medication and psychological work. But that's so important. But yeah, Dan, I just wanted to ask your view on this. I mean, do you think the early treatment makes a difference, and does it sort of help in terms?
Absolutely. Yeah, absolutely. That's a great point. And for the reasons you said, we want to have the developmental trajectory being in a positive way and unlearn certain reflexive reactions. So at NIMH, which is just down the street from me here in Rockville, Maryland, in Bethesda, there is a wonderful group that do an irritability study, the Mood Disorders Clinic, headed by Dr. Ellen Liebenluft, and the psychologist on that team, Dr. Melissa Brotman, Brottman, is looking at cognitive behavioral therapy for children with irritability. The same principles that we use for CBT for anxiety are applied to kids with irritability. Instead of, hey, what triggers the anxiety? Let's do gradual, incremental, increasing exposures to the anxiety triggers. She does the same thing regarding the irritability, if you will, anger issues, where she will give the kids, with warning and with practice, a little dose of things that upset them and say, hey, I want to teach you how to manage this. And then a little more, and then a little more, and then a little more. It's to help the kids learn, hey, what triggers me? What can I do? So this is just a little expansion on what we mean by one type of non-pharmacologic program in combination with best medication.
Wonderful. Thank you for that. So we really want to wrap up and not keep you all too long. So again, a parting word. What would be the key thing that you would like people to remember from tonight's session about ADHD medication? I know Dan said something earlier, but you can always add to it, or and Dr. Bhanu as well. Really, if people just remember one thing, what is the most important thing to remember? Maybe Dr. Bhanu, you go first, and then we'll let Dan end on that one.
I think Dan has really given us very good reasons on why one should consider having treatment, particularly the medication. And I think one thing that I would like to say is medications are effective, and multimodal treatment, or treatment that involves medicines plus psychological or coaching, they are even more effective. Yeah. So one should consider both if you are trying to go for the treatment.
Thank you. And Dan?
And Bhanu, it's been wonderful doing this with you. I find that we're philosophically very much of the same mind, and I appreciate the opportunity to listen to you. And yeah, my message is don't give up. This is a lifespan issue. It's not something you need to solve tomorrow. It takes work, it takes time. Hang in there, and you'll see that over time, with some ups and downs along the way, be realistic, things will be better. So I wish you all the best of luck, and Moonlight, thanks for the opportunity to do this with you again.
So everyone have a good night and good morning to you, Dan. And thank you, everyone, for doing this. Let's keep in touch. Take care. Good night, everyone. Bye.